and welcome to Let's Talk. It's our podcast series produced and offered to you from Hazel and Betty Ford. I'm your host, William C. Moyers. Thank you for joining us. Harm reduction is our topic for today. It's not a subject we've tackled before for a lot of reasons, in part because it is a lightning rod for oftentimes divisive debate or discussion. And frankly, Hazel and Betty Ford's expertise isn't necessarily applicable to some of the challenges and approaches that make harm reduction so important and in some circles so contentious. Our guest is Dr. Lipi Roy. She's a doctor of internal medicine with an expertise and passion for helping people who struggle with substance use disorders. Joining us from New York City today. Welcome, doctor.
Hey, greetings, William. How are you?
I'm doing fine, thank you, and thanks a lot for joining us for this Let's Talk podcast. Tell me, where do you get your interest in addiction medicine?
You know what, William? I fell into it by accident. I did my residency in internal medicine from Duke, and then my first job, I served as a primary care doctor to Boston's homeless population. And about a year and a half into the work, one of my colleagues did a research study looking at mortality among Boston's homeless population and found that the leading cause of death amongst our patients was drug overdose. This is back in about 2013, before we saw these daily headlines of opioids and heroin and now fentanyl. And so, because prior to that, the leading causes of death amongst homeless men and women were typically heart disease, cancer, HIV. So the fact that it was drug overdose really took all of us by surprise. And that's what prompted me to learn more about addiction, substance use disorders, talk to people that do the work like psychologists and therapists, and really talk to and counselors. And then I got trained formally in addiction medicine, got board certified in that. I go to conferences. So even to this day, I'm trying to learn more and more about this fascinating field of addiction medicine.
Well, and you're a very eloquent and knowledgeable spokesperson for these issues. I've been very intrigued to hear some of your insights offered in the public arena. Talk to me and talk to us about harm reduction. What is harm reduction from your perspective?
So I'm so glad we're talking about this topic, William. Harm reduction, first of all, is not a new concept. It's been around for a very, very long time. What's unfortunate is that it's not really formally taught to people like me, doctors or other healthcare professionals, in a formal setting. So all the things that I'm about to talk to you today, William, I have been really on the job training, from on the job learning. Harm reduction is really, it's a set of strategies and ideas aimed at reducing the negative consequences associated with drug use. It's really a social justice movement that's built on a belief in and a respect for the rights of people who use drugs. And it's a spectrum from safer use to managed use to abstinence. So the premise of harm reduction isn't, oh, you have to stop using all drugs, all alcohol now. It's a spectrum. And the motto of harm reduction is to meet people where they're at.
What does that mean, to meet people where they're at?
So I'll give you a perfect example. I had a patient who I saw, who uses, say, 10 bags of heroin a day. I asked, motivational interviewing types of questions. Tell me, what do you enjoy about heroin? And they'll tell me X, Y, Z. And then I'll say, describe to me what life might be like without heroin. And if they say, doc, I need it because it helps my anxiety, or it helps my pain. But then I offer, I basically want to get them to what their goal is. If their goal is to not quit, but rather but they want to cut back, then I say I'll offer XYZ harm reduction tools. It could be medications like Suboxone or buprenorphine. It could be maybe they just need food and socks. Maybe they're cold and heroin helps warm their bodies. So harm reduction means offering whatever services to meet them where they're at. If they tell me they want to quit completely, then I'm going to get them the tools to get them to quit. But if they just want to be able to cut back, or it's meeting them where they're at, what do they need, and let's get them to what they need safely. So maybe that means, hey doc, I still want to use heroin, but I can only find dirty needles on the street. Okay, let's get you clean syringes. And let's get you, if they say that I'm at risk for having unprotected sex, then let's get you condoms. You know what I mean? So harm reduction includes clean syringes, naloxone or nasal Narcan to prevent overdoses. It includes condoms, care coordination, food, legal services, education, jobs, health services. It's a spectrum of examples and tools to keep people safe and alive.
On that spectrum, is treatment a dynamic or a component of the spectrum?
It absolutely is. So medications, we often think of medications as being treatment or cure, but it actually can also be harm reduction. So I have patients, for instance, I've started patients with opioid addiction who I've now started on, say, buprenorphine or Suboxone, which is one of the gold standards of treatment for opioid use disorder. I'll have patients say, doc, I am still using, but I'm down to just one bag of heroin a day, as opposed to 20 bags a day, or I'm down to like 1 or 2 a week compared to 20 bags. You know what I'm saying? So they're not running around desperately trying to chase down a bag of heroin. They're not, say, a lot of cases with women and men too, selling their bodies.
Yes.
They're not putting themselves in harmful situations to treat what is otherwise known as a medical disease of the brain.
Mm-hmm. And treatment in a harm reduction model can be, to your point, medication. It can be outpatient. It can be motivational interviewing, or it could be residential, yes?
It can be all of those things, William, and as well as all the other examples that I gave. It could be condoms. Yes, it could be medications. It could be clean syringes. It could be overdose prevention centers. It could be providing a safe space where they can use without fearing being attacked or mobbed, or, so it's a whole, it could be socks. I have given patients socks. I've given them job applications. People just, we still have a very archaic attitude when it comes to drugs in this country, William, and that needs to stop. Most people, not all, but many people use drugs to self-medicate their pain and suffering. And I frankly don't think it's my duty to tell somebody you have to stop using a drug unless I'm prepared to replace that drug for whatever reason they're using it for.
Great point. So why is it that in the United States, at least, harm reduction is such a polarizing or lightning rod issue?
The short answer, and this is just my opinion, but I believe it's because it's so grossly misunderstood, William. I think that, and I get it. I'm coming to you from a position of humility. For most of my career, I didn't know what harm reduction was. To be honest, I never even heard of methadone until I got into the field of addiction medicine. So I think for most people, it's lack of education, lack of awareness. And now that I know what harm reduction means and that it's a way of keeping my patients safe and alive, and it's, by the way, it's evidence driven. I don't want your listeners to think, oh, this is all Lipi's opinion. It is not. We have decades of studies showing that harm reduction is a data-driven tool to keep people alive and safe. And there's a spectrum, as I just mentioned, from condoms to clean syringes to the other end of the extreme, creating safer injection or consumption sites or overdose prevention centers. So I think people might have issues with the different types and different levels, but I think at the core of it, I think most people just don't really know what it is. And if they knew that it meant keeping their loved ones alive and safe, I think they'd be far more in support of it.
We don't have time on our podcast today to go down this route, but I want to at least raise it, and perhaps we can have you on another time to talk about it. But where does legalization fit in a harm reduction spectrum?
Yeah, so that's kind of is somewhat related, but it's not necessary. If you ask me, I do think that drugs should be decriminalized because, unfortunately, in our current system, drug use disproportionately impacts people of color, and they get, unfortunately, more of a criminal justice and punitive treatment as opposed to people who are not of color, white folks mostly, who get treatment. So that needs to stop. So I don't, legalization is a different topic. Harm reduction doesn't require that. Harm reduction, because there's so many different types of tools, there's just many ways to keep people safe. I do think, however, that overdose prevention centers should be legal, should be allowed, and should be widespread because they exist in many other countries. Here in New York, we do have a site on Point, NYC, that allows that, but it's nowhere near as widespread as it is in countries like Canada, in Netherlands, many other countries in the world.
Can you talk a little bit more about what exactly constitute an overdose prevention site?
Sure. In fact, I'll tell you about the one that I visited in Vancouver. Insight was actually North America's first legalized supervised injection facility or supervised consumption site, overdose prevention centers. Those are all same names for the same site. And these sites, like the Insight in Vancouver, provides a continuum of care, addiction, mental illness, HIV/AIDS. There are many addiction, mental health counselors and peer staff on site that connect people, clients, to housing and addiction treatment and other support services. Again, there was a lot of controversy when they first started back in 2003, but Canada now has multiple overdose prevention safer consumption sites throughout the nation. But the key point, William, I want to make clear is that once I discovered the data, that the fact that these sites save lives and improve health, I can't not know that. So for instance, these supervised consumption sites there are over 60 around the world have been associated with a decrease in IV drug use, a decrease in overdose deaths by over 30%, decrease in HIV and hepatitis C transmission, increased connection to treatment, no increase in drug-related crimes like trafficking and robbery, assaults, and zero fatalities. I bring this up because I want people to know that these consumption sites are data-driven. Globally, we know they save lives and they improve the quality of lives. So unfortunately, we get a lot of pushback from, say, law enforcement and policymakers who don't understand or who have their own preconceived notions of what these overdose prevention centers are.
Can you talk about overdose prevention centers or clean needles or those other mitigating factors in the context of the role that counseling plays in that?
Well, I'm a big fan of any type of behavioral therapy, which includes either individual or group counseling. I'm a big fan of that because, again, as a doctor and a former scientist, I'm about what works, what science has proven to work. And we know that behavioral therapies, counseling are evidence-based. We know they work. And in fact, the people who have the data shows that people who have the best outcomes for short and long-term recovery are those who receive a combination of both medications and counseling when medications are available. So, the truth is, William, that most people who experience substance use disorders, they feel tremendous shame, embarrassment, guilt. This is all stigma that's associated with it. But when we can, and they feel isolation because of these emotions of guilt and shame. They feel isolated. They don't want to talk about it. They're afraid. They're guilty. But counseling is a means of connection. You've probably heard the expression, the opposite of addiction isn't sobriety, it's connection.
Yes.
So we can make that connection with, say, a counselor or a therapist or a doctor or a nurse or whoever they trust in society, whether it be a neighbor, a plumber. I don't care, as long as they connect with somebody and they feel like they're not alone. I think that's a critical first step in connecting people to the care that they need and deserve.
Absolutely. We believe that at Hazel and Betty Ford too. In fact, we're a 12-step abstinence-based approach, although we are evolving in terms of our delivery of care and how we define recovery. But nevertheless, the 12 steps are integral, and that first word of the first step of the 12 steps is precisely what you talked about: we, community. And I think, addiction being an illness of isolation, the antidote to it is exactly what you suggested, which is community, that sense of we. What have you seen as a doctor who practices in this field, in this space, between the opioid epidemic and the pandemic of coronavirus? What has that done to people who are struggling with substances?
Oh man, what a great question. And it's really unfortunate. It's really been a collision of epidemics, to be honest. What we're seeing is that, and public health advocates and health professionals like me, we're a little responsible insofar as the data showed, especially in the beginning of the pandemic when SARS-CoV-2 was spreading like wildfire and we didn't know how to contain it. We were still learning about it. What we did know from decades of data on infectious diseases is that isolation, being in lockdown, that was the first kind of immediate response. And that was a public health measure that helped with this infectious disease crisis, but it also made things worse for frankly human nature. We humans by nature are social creatures, but it made it exponentially worse for people with substance use disorders who really rely on connection. Again, that connection could be with a therapist, with I'd say an AA counselor, with a doctor, with a nurse. So we have data showing that the pandemic made substance use disorders considerably worse. Heavy drinking went up, methamphetamine use, stimulants, you name the type of drug, the substance, because people felt depressed, lonely, angry, they were unemployed, they were all of these different emotions, and they were self-medicating with drugs or alcohol, which has always been the case. The pandemic made it considerably worse.
There are a lot of people who are opposed to harm reduction, in part because they argue that it sort of writes off the addicted person. It doesn't give them a way out of what they're in. What's your response to that?
I'm confused by that response. It doesn't make sense to me. I would want to explore that a bit more for the person who's voicing those concerns. To me, it sounds like it's rooted in maybe just a lack of understanding of what harm reduction truly is. Because harm reduction really, it starts with respecting the person who's using the drugs. Mm-hmm. So if you're the person who believes that drugs are wrong, then you're coming from a place of judgment. Right? I think it goes back to respecting the rights of people who want to use drugs and being there for them should they develop an addiction or a disease of the brain, like a substance use disorder. So I believe that it starts with that. That's where the kernel of disagreement lies, which is not respecting a person's right to drink or to use drugs.
Right. Dr. Roy, before we go, I want to put you on the spot, so to speak, and I think that'd be hard to do anyway because you're quick on your feet. I can tell. I'm very impressed. But when we talk about harm reduction, when we talk about how we address addiction, we need the medical community to be part of the solution. And yet we know at Hazel and Betty Ford, and I'm sure you would agree, that too often medical schools and institutes of public health don't teach addiction in med school or in graduate school. What does the medical community, where is its responsibility in learning about addiction? Where is its responsibility in the debate about harm reduction?
Well, I'm glad you're putting me on the spot, as you should, because it is the responsibility of the medical profession to provide evidence-based care. And I think I stated right from the start that unfortunately, almost everything that I'm talking to you about today, William, I learned from on-the-job training. Yes. But the good news, and So that's a major reason why I do a lot of these talks, these trainings. I speak nationwide, I speak globally actually about the intersection of addiction, homelessness, mental illness, pain, trauma, incarceration, because most healthcare professionals, whether they be doctors, nurses, NPs, PAs, we don't learn that from our formal training. I am optimistic, however, that things are changing. Certainly here in New York, at a city, state levels, we are incorporating more trainings, free trainings on opioid use disorder, substance use disorders, alcohol, evidence-based treatment. We are doing that here, and I know for a fact that many, many states are doing that, and federal agencies like SAMHSA, as well as organizations like ASAM, American Society of Addiction Medicine, as well as a lot of nonprofits, organizations like Shatterproof. I'm very optimistic, not to mention organizations like Hazel and Betty Ford, which has a huge education foundation and wing. I'm very optimistic that things are moving in the right direction. But I'm your typical type A doctor. Things have happened fast enough. But I am optimistic. We just need to have more of these partnerships and collaborations to make sure that people that are in positions of power, decision-making positions, make like doctors, but also judges, prosecutors, and elected officials, policymakers, they are all trained in these critical areas.
I agree, and I do feel that change is in the air. Just the fact that we've had you as one of our guests on this podcast tells me that even Hazel and Betty Ford is part of that evolution on drug policy and on approaches to treatment. And again, to your point, emphasizing evidence-based outcomes, evidence-based care. So I want to thank you, Dr. Roy, for taking the time to be with us today and for sharing not just your expertise, but clearly your passion and your commitment to helping people. We'll have to make sure we have you on again to talk about some other things. Dr. Lipi Roy, thanks for joining us today.
My pleasure, and thank you for all the work that Hazel and Betty Ford has been doing. It was a real pleasure.
Thank you. Well, there you go. Changes in the air on this podcast as well, and we're glad that you are part of this remarkable crew at Blue Moon Productions, as well as our executive producer, Lisa Stengel, who worked very hard to bring you the very best and the very latest when it comes to the issues around addiction, research, treatment, prevention, and harm reduction. So, on behalf of all of us at Hazel and Betty Ford, thanks for joining us, and we hope to see you again soon. Take good care.